And I'm going to demonstrate two common cases that we see in our cataract practice, the toric patient and the post-refractive patient, and how I implement the Pentagram and also the Keratograph 5M as I work up all my cataract pre-op patients. So this is just a photo of my diagnostic area where I have the German table where it incorporates both the Keratograph 5M, which I use for pre-screening all of my cataract patients for ocular surface. As we know, treating ocular surface is crucial to get our optimal outcomes that we want, especially in our premium IOL patients. And of course, the Pentagram AXL on the left. And just like Dr. Wiley alluded to, this really speeds up my flow for how I work up my cataract and refractive patients in my clinic. And it's kind of a one-stop shop to get a lot of information, prior to your technicians dilating and putting dilating drops in the patients. I get a lot of information that I can use in preparing for treatment of our cataract patients. And so again, case one is a toric cataract patient, and the second case is a post-refractive cataract patient. And so again, when we do our toric IOLs, it's all about looking at looking for a regular astigmatism, which the Pentagram and also the Keratograph topography SimKs are crucial into getting those correct numbers for us and determining the source and the magnitude of the astigmatism to correct, and the proper axis, which is, of course, with the total corneal refractive power that we've been talking about this morning. And so here I have a young patient, 44-year-old patient with visually significant PSC cataracts who had significant glare driving, been in toric contact lenses most of her life, no other ocular disease, and she's high myopia, minus 775, with regular astigmatism. On her auto Ks, they matched what the manifest said. And so planning on doing her right eye first, but of course, the Keratograph 5M really helps me in looking at ocular surface pathology prior to cataract planning. And she's a level 1 here, and so treating her with just artificial tears and tuning up her cornea prior to cataract surgery is very helpful. And so looking at her, what we're so used to with people here that have had Pentagram is just looking at her refractive maps of her right and left eye, and she's got pretty regular astigmatism with the rule and good corneal thickness. And so where the money is on the Pentagram AXL is the cataract pre-op display, where it gives you that wealth of information, what we've been talking about. And so you can look at the higher order aberrations of the patient, again, looking at regularity of their astigmatism and axis, and of course, looking at spherical aberrations. And that helps you determine whether you're going to use a aspheric IOL or a spheric IOL or neutral IOL. And I've used the Pentagram to actually change IOLs in those situations, and then looking at the angle and magnitude of the astigmatism. So like on this patient's pre-op display of her right eye, she's got, again, regular astigmatism, 1.7, and it's only a 0.2 difference between her total corneal refractive power, and the axis of alignment is pretty spot on within about 1 degree. So I feel confident about where I'm going to place her toric IOL for this patient. And again, her spherical aberration is of 0.129, so you can use that to kind of guide you whether you're going to use an Alcon toric versus a Johnson & Johnson or AMO toric lens if you're trying to neutralize her spherical aberrations. And then this display is very helpful because I have big screens in each exam lane, so I can pull this up and show the patient exactly what their astigmatism is and answer their questions that they have. And it really helps me explain to the patient and get them to their target goal. And it helps for conversion to toric and enhanced depth focus IOLs in my practice. And, I can look at this and say if they have too much spherical aberrations, then that may eliminate them from one of the options that we don't want to put in and get an unfavorable result. And so I like the display here because this is really customizable for the practice. You can put up to, I think, 25 different surgeons and many different IOLs of your choosing under these different tabs. And as I highlight here in yellow for her, we're choosing she was looking to get out of, or be less dependent upon her spectacles. I mean, she's young, 44 years old, and so I'm planning on doing an enhanced depth focus on her. And I like the customizable of this screen, that you can make it the way you want. And it has different parameters that show up if you're outside the bounds. For example, if you're greater than 0.3 millimeters in axial length, you'll have, it'll flag you so that you can look more into it. And so also there's a toric tab where this is the Savini toric. And so just one click of a button, you can get a wealth of information about where you're going to plan for your toric IOL patient. And so I love the printout of this. This is what I take to the OR with me, and it has a lot of the data that we've been talking about on one printout. And then I put this and bring this with me to the OR and have this on hand. Planning for a 12.5 diopter lens with a 1.5 axis of astigmatism, and she did really well. 1 week post-op and landed on target. So take-home points, again, we've been talking about this morning, is that, correcting astigmatism, surgical planning, we need to consider the total corneal refractive astigmatism. And, of course, the SIMKs only measure the anterior surface, but you have to know what's going on with the posterior surface, and the Pinacam AXL gets you there. And as Dr. Balin mentioned, too, at the bottom part, incorporates both the anterior and posterior corneal shape with thickness, using the ray tracings to produce the total corneal refractive power. In the second case, post LASIK, we see a lot of these patients that are coming of cataract age. Here I have a 59-year-old female with visually significant cataracts, and that she's prior myopic LASIK in both eyes, and her dominant eye is the left, and more astigmatism on her left eye, and that's the eye I'm going after first. And so looking at her for map refractive, she's got axis about 120, oblique astigmatism. And I like how you can see their her oblate cornea where she's had post-refractive surgery. And sometimes patients don't know whether they were far-sighted or nearsighted, and they don't know what type of excimer laser they had. And so this helps kind of guide you along that path if you don't have any data prior to the patient getting there to your clinic. And in this case, again, the cataract Preop Screen, she's got pretty regular astigmatism that agrees with both the SIMKs and the total corneal refractive power, with only a 0.1 difference in axis with the same magnitude. So planning on getting her, correcting both her astigmatism and considering her post-refractive cornea to get her her goal. And so, again, here's the tab that you see with the printout on the IOL calculator. And if you can see, if I didn't know that she had LASIK before, would go with this 21 diopter lens. But when you click on the post-refractive tab, it's actually a 21.5 diopter, which I would have had a hyperopic surprise in this case had we not had the post-refractive calculator built into the Pinacam. And this is using the Hill, Pott, Van Shamas post-myopic calculator here. And so did very well. And so, with one click of a button, you can get all that data that you need. And so this is the formula built into the Pinacam calculator for in this patient's selection. So pre-op workup, it's important to look at that anterior segment health of the eye before you plan accordingly. You want to fine-tune the cornea prior to cataract surgery. Again, topography and tomography, easy, precise measurements for axial length, looking at higher-order aberrations, corneal shape, spherical aberrations, and the cord value, too, to see what the candidacy is of the patient. You get all that with the Pinacam AXL here, and the software and surgical printouts. Thank you.